NEET PG recall question discussion, subject physiology, of course. The fun part with these recall discussions is that I used to tell one student appearing for the exam to get me the physiology questions immediately after the exam. One student appearing for a 300 MCQ exam and picking up physiology questions from that would be very difficult for that student, and he would not remember the questions correctly. Then I started telling 5 different students to remember the physiology questions and tell me those questions. 5 different students would narrate the same question of physiology in 5 different ways, and therefore one wouldn't know actually what came in the exam. Well, this is quite understandable because the students, their job is not to remember those questions for us, but their job is there's a lifetime opportunity and a very important matter, and therefore their focus is on solving those questions rather than remembering the questions for us who are sitting outside. Anyway, and therefore what I would urge you to just look at the topic on which the question has come, because that is more important. We scan all these questions over the years and then we understand, okay, these topics are repeatedly asked, and then we concentrate more on those topics even while teaching. That's the importance of these recall questions. I also find it little amusing and amazing that the people claim that this question came directly from my teaching. It happened with me actually, that one question came and it was only there in one of my video lectures, and therefore students themselves after the exam started pointing that, sir, you taught this and it came from here and it was taught only on this platform. But look, I haven't taught it something like very exclusive. I must have taught it from some book, Guyton, Ganong. So at this rate, tomorrow Guyton and Ganong will start claiming, look, the question was asked from our book. So therefore, that also is there. Whatever we teach, the questions will be asked either directly or sometimes in a modified way. So you just have to apply your mind where you have seen that topic and make that application successful in solving the answer, solving the MCQ. Okay. The first question was on the transport processes. They have given a diagram and they are asking what type of transport process is this. I urge you again not to look at the question itself or the options, but see the topic on which the MCQ was asked. So this diagram is given. Now look, they have mentioned it as a carrier protein. Okay. So this is a transport process through the cell membrane, and there are 2 types of when the carrier mediated transports are of 2 types. One is facilitated diffusion and the other one is secondary active transport. Okay. Primary active transport is an ATPase, it's a pump. Generally it is not called as the carrier protein, and therefore carrier mediated transports are only these 2, facilitated diffusion and secondary active transport. They have shown the substance transported from high to low concentration. Remember, in facilitated diffusion only a single type of substance is transported, and that too from high to low concentration, whereas in the secondary active transport 2 different type of substances are transported by the carrier. One of them is going from low to high concentration. That is not shown in this diagram. So obviously this is facilitated diffusion. They had given the options whether it is simple diffusion, facilitated diffusion, primary active, secondary active, etc. Anyways, that was simple. When you see a figure or a graph, first thing that should come to your mind is where, in which chapter and in what context I have seen this. If it is completely new, look at the units at least. Units, parameters, something mentioned in that very new diagram, and from there try to resolve the matter of the MCQ. Okay. So second question, again don't look at the question but look at the graph given by them. This was the graph given. All right. Anyways, this was a graph related to the kidney, and the graph is asking that substances were filtered at the glomerulus, and then what happened to those substances as they started traveling down the tubules? They traveling along the nephron, and from that you were asked to identify those substances. Let's take the example of C, which is shown by the straight line here. And on the vertical axis, percent of the filtered load remaining in the tubules, that is shown on the vertical axis, and horizontal axis is the places in the nephron. So, look at the substance C. Once it was filtered, and this is the 100% line, the substance just is not changing at all. Concentration across the tubule is neither increasing nor decreasing, which means this substance, once it was filtered, it is neither reabsorbed nor secreted by the tubules. Hence, a straight line, not increasing or decreasing across the nephron. See, proximal tubule, distal tubule, into the urine also, and therefore this must be inulin. Okay, this is inulin. Remember, inulin, it is freely filtered at the glomerulus and then neither reabsorbed nor secreted by the tubules. Therefore, its concentration will remain the same across the entire length of the nephron in all the segments. Whereas, compare that with D and B. Substance B has been completely or maximally reabsorbed in the proximal tubule. So, its concentration has decreased in the proximal tubule and then remained the same, which means what? It was reabsorbed maximally in the proximal tubule and then it whatever was appearing in the urine, whatever little, but mostly reabsorbed from the PCT, that is the substance B, and substance D, its concentration has increased in the proximal tubule and then that concentration remained the same along the remaining part of the nephron. So, B was reabsorbed from the PCT, from the proximal tubule, D was secreted in the PCT. So, B substance is definitely glucose or bicarbonate. These are substances which are reabsorbed from the PCT. Substance D must have been H plus ions. H plus is secreted in the PCT. So, its concentration increases in the proximal tubule. Therefore, that is how you should read a particular graph and understand what is happening actually in this graph. When the student came out, he said, sir, something like insulin was in the option. I said it was not insulin, it was inulin, because they were saying whether inulin neither reabsorbed nor secreted. That property was being discussed in this particular graph. Anyways, a 25-year-old patient came OPD with the diagnosis of hemolytic anemia. Now, due to hemolysis in this patient, the potassium levels were elevated. What will happen to the RMP in this patient? Well, that was the question. When the potassium levels increase, what happens to the RMP? That's the question. Now, look, if the potassium, take any cell, whether it's nerve, muscle or a cardiac cell. Cardiac cell has got a little different response as compared to nerve and muscle. Look what happens to the cardiac cell, myocardial cell. Potassium starts going out by concentration gradient and that causes repolarization. Okay. Now, imagine that in the given question, ECF potassium has increased. That is what they said. Hemolysis has happened and because of the RBC breakdown, the potassium levels have increased in the serum. Potassium means positive charges. So, positive charges have increased and many of those positive charges, they line up just on the outside of the membrane. Okay. So, an electrical gradient gets created across the membrane from outside to inside. Can you imagine this? Please go through the chapter of this RMP and the relevant information related to the ionic movements. So potassium, generally for any cell, it starts going out by concentration gradient, and that causes repolarization. Okay. But if there is increased ECF potassium, those potassium ions and those positive charges, they begin to accumulate just outside the membrane, and an electrical gradient gets created, gets established across the membrane from outside to inside, more positive charges on the outside compared to just inside. So this is an opposing force for the potassium. Therefore, the potassium exit by its own concentration gradient will decrease, and this intracellular potassium will just come near the membrane on the inside. Always remember, when we talk of any membrane potential, we are talking about just inner aspect of the membrane, the potential on the inner aspect of the membrane. So potassium will now start coming near the membrane and will start accumulating near the membrane on the inside. Which means what? Which means the membrane will move towards positivity. And that is what was asked in this particular question. The question was, if the ECF potassium increases, if the potassium in the ECF increases, what will be the effect on RMP? It will become slightly more positive. It will move towards positivity because of this. Okay, RMP is the membrane potential on the inner aspect of the membrane. Why it will become slightly more towards positivity? More towards positive means it will become less negative. Okay, positive does not mean plus 35. In this case, RMP slightly becoming more positive means less negative it will be. From minus 70, it will move to minus 65, something like that. Okay, so that's what happens. The potential will become more positive. These were the options. It will it become 0? No, it won't become 0, or it won't become plus 35, but it will be slightly more positive. Whereas if the serum potassium decreases, then what will happen? Potassium going from inside to outside, that concentration gradient will widen, it will become wide. Excess potassium will leave the cell and there will be hyperpolarization. In that case, we will say the RMP becomes more negative. Okay. If the serum potassium has fallen, has decreased, then excess potassium will go from inside to outside because of concentration gradient. But the question was simply on this, whether you understand how the potassium moves during repolarization and what is its effect on the RMP. Alright, let's take one more question. A 25-year-old person had a road traffic accident with his vertebra sectioned or damaged, injured. On investigation, it appears that the dorsal column of the spinal cord was hit from the lateral side. Oh, that's very precise. Dorsal column, and that too it is hit from the lateral aspect. Which of the following will be affected in this person? Ipsilateral arm, ipsilateral leg, contralateral thigh, or ipsilateral thigh? It will be ipsilateral side that will be affected, means sensation will be lost from the ipsilateral side. Why is that? Let's try to figure out this question, what they are asking. Look, they are saying whether you know the dorsal column in the lower limb regions, the fibers carrying fine touch, pressure, vibration, proprioception, they enter the spinal cord, and in the lumbosacral segments they start running upward. Let's say this is the dorsal column, dorsal white column, and the fibers in the dorsal white column. As they ascend upward and they reach the thoracic and then the cervical regions, the fibers from the upper limb will join them. Okay. So here is the fiber from the upper limb. joining this fiber which has come from the lower limb fiber here, and upper limb fiber placed laterally. This is the upper limb fiber. Upper limb fiber, as it enters the spinal cord and enters the dorsal white column, it pushes the lower limb fiber more towards the midline. As you can see here, this was the lower limb fiber. It started ascending upward. It came here. Upper limb fiber has joined it. Then that the lower limb fiber is pushed near the midline, towards the midline. And that means, and the one more fact that you should have noted is that the fibers have remained on the same side and they are ascending upward. So, if the damage is like this, dorsal column damaged in the cervical region, and from the lateral aspect, like this, from the lateral aspect, this is the midline, this is the lateral part. In that case, which fiber is likely to be damaged first? Ipsilateral fiber, and that too from the upper parts of the body, because laterally placed in the dorsal white column is the fiber coming from the upper limb. Okay, that was the question. Basically, many students had lot of confusion about this question. Some students said these were the options, some students said no, the options were different. But ipsilateral arm, if this exactly was the question, then ipsilateral arm would not feel the sensations after such type of an injury, because those fibers will be damaged in such type of injury or accident. So, basically you had to know the dorsal column and how the fibers are arranged in the cervical region. From lateral to medial will be first the upper limb, then abdomen, then the lower limb, from lateral to medial side in the dorsal white column. Okay, this is a graph given of action potential, and then 5 points were marked in the graph, and then they are saying which statement is correct. Even in this, when the students came out of the exam, every student was telling me some different options. So, I have tried to see some sense in those options. Point B to D is the absolute refractory period. Okay, point B to D is the absolute refractory period is a correct statement. Point E is threshold. No, that's not right. Point D is due to closure of sodium channels. No. Point D is after depolarization. Okay, when potassium exit decreases. And point B is related to potassium channels. Again, not true. Point B is sodium channels. So, basically it's about action potential and its phases. And you can go through the discussion on action potential. I have discussed this extensively even there. And B to D is the refractory period. Yes, that's right. I have marked it in the graph in the main discussion. So, just go through that once again. A is RMP, then B is threshold, then after the threshold C is spike, and then D is after depolarization, and then E is RMP again. So, or before that, just a dip in the graph is hyperpolarization, and they are asking this phase is because of which ion, or what this phase is called, etc. Therefore, well, point B to D is the absolute refractory period. Yes, that's the correct option. That's the answer in this particular MCQ. Right. But the point is, just go through the action potential once again, because in my opinion, every alternate exam, one question is on action potential. These are the darling topics of physiologists. Action potential is one of them. Muscle sarcomere is one of them. Lung volumes and capacities, darling topics of physiologists. Okay, they will always ask compliance. So, such topics one should revise before any exam. Okay, see, as I said, lung volumes and capacities. The spirogram is shown, and there is an arrow in the green, and it is asking what is this volume or capacity. Now look, tidal volume they have shown, quiet inspiration the graph goes up, quiet expiration the graph comes down. You have to have this knowledge first. And the green arrow is beyond the quiet expiration. Okay, so this part above the quiet inspiration is inspiratory reserve volume, and the part below the quiet expiration is expiratory reserve volume. So this would be the expiratory reserve volume. This one beyond the quiet expiration, this will be expiratory reserve volume. So if it's for the spirometry cannot measure the FRC, functional residual capacity, but since they have shown here in this graph, we can say with certainty that this is what they had shown was functional residual capacity, because this line represents residual volume. I mean, with forceful expiration the person reaches here, and the part below that is the residual volume, and therefore expiratory reserve volume plus residual volume, ERV plus RV is FRC. So this graph was asked, this can come again and again because it is easy to ask such questions. Give the graph and ask the question. You just have to know one thing in such questions: the graph going up is inspiration, the graph coming down is expiration. Okay, and then this is the tidal breathing, and just have a look at above the quiet inspiration and below the quiet expiration. That's it, and you get to know the volume or capacity. You can answer that. Okay, a premature infant was suffering from infantile respiratory distress syndrome. So which of the following would be lacking in this? You know, respiratory distress syndrome is because of the lack of surfactant. So obviously this was lack of surfactant. And what was lacking? Lecithin, sphingomyelin, phosphatidylserine or phosphatidylethanolamine. Now most important factor in the surfactant is the DPPC, dipalmitoyl phosphatidylcholine or dipalmitoyl lecithin. Okay, and whether the lungs have matured or not, that also is diagnosed with the ratio which is lecithin to sphingomyelin ratio. If this ratio has become 2:1, we will say lungs have matured and they are producing enough surfactant. Okay, lecithin to sphingomyelin ratio 2:1 gives you the idea about maturity of the lungs and production of surfactant. So most important substance that was lacking in the premature infant will be the lecithin. Most important constituent of the surfactant is dipalmitoyl lecithin, and in the amniotic fluid what you look for is the lecithin sphingomyelin ratio of 2:1 for the maturity of the lungs. And there was one more question along the similar lines, that a preterm infant was delivered around 28 weeks of gestation. Which of the following is the will be there in the infant compared to adult? In the infant lungs, what would be there compared to the adult lung? And they have given the options: surface tension is higher, or surface tension is lower and compliance is higher, or surface tension is higher and compliance also is higher. Surface tension low, compliance is low; surface tension high, compliance is low. I think that those must have been the options. These were the questions sent by a student, and therefore I am just assuming a few things. I repeat this third time now because you might see some errors and might say that, sir, these are all the errors in your teaching. No, these were the questions sent by a student. Okay, so anyways, we are not bothered by that. We are interested in seeing what topic was asked. So again, if the surfactant is absent, then what will happen to the lungs? That is the topic. If the surfactant is absent, that means surface tension will be high and compliance will be low. So look at the options: surface tension will be low and the compliance will be, I beg your pardon. Did you note something? What did I say? If the surfactant is absent, surface tension would be high. Surface tension would be high because that was the job of surfactant. So, surface tension would be high and compliance, the distensibility would be low. It will be very difficult to distend the lungs. So, which one of them is fitting here? Surface tension is high and compliance is low. That is the option D, and therefore, that is the answer to this particular MCQ. Then finally, there was one graph, cardiac action potential, and they had given options asking which ion is responsible for which phase. That is very common. Calcium channel opens in the phase 2 at the end of phase 1 and start of phase 2, or potassium channel closes at phase 0. No, sodium channel closes at phase 0. Phase 0 is rapid upstroke and that is by fast sodium channels. This is action potential in the Purkinje. Then transient sodium channel open at phase 3. That is also not correct. At the end of phase 3, potassium channels are going out and that potassium exit will stop at the end of phase 3. So, even that is not right. Calcium channel closes at phase 4. That is not right. Calcium channel closes at the end of phase 2. This plateau phase is because of the calcium influx through calcium channels, and therefore, the only correct statement in this is the calcium channel opens at phase 2, start of phase 2, end of phase 1, and that calcium influx is responsible for the plateau phase, phase number 2. So, these were the questions which were asked in the NEET PG 2023 physiology section. Topics are important. So, whenever you see such videos, you know the topics which have been asked, then immediately start revising those topics. That would be a wise thing to do.